Welcome to the St Emlyns podcast. I'm Ian Beardsall. Welcome to the St Emlyns podcast. I'm Ian Beardsall.
And I'm Simon Curry.
And it is 30 degrees outside in the UK. This is another heat wave. I don't know when 4 heat waves become one long heat wave, but it is still baking hot summer here in the UK. We are sitting at desks hoping to get a podcast recorded for you to cover the June and July content from the blog. But Simon, there's so much going on, and it's why we've been a bit quiet and why the blog has been a bit quiet. You've been a very busy man.
We've got lots of many and interesting things to do and to get around different places. So I was in Hyderabad recently, examining for the college. That was really good fun. I met some really fantastic people and really great candidates and some amazing trainers out there. Emergency medicine is going strong in India, doing really well.
There's plenty of other stuff going on, I know, with your work as the dean and all those other things. Things don't seem to slow down in summer.
No, there's an awful lot of work going on. The work of the college goes on, but also there's a lot of anxiety around things like days at the moment. So the Leng review has just come out recently. We've got the 10-year plan, which has come out. We've got the medical training review from Chris Whitty, which is going to be coming out soon. All of these can have fairly profound impacts on emergency medicine here in the UK. And yeah, quite a really interesting and exciting times.
And there are a couple of things that we can look forward to, though, and it's worth giving a little promo to. Just a couple of conferences to mention. We often do this, but we would encourage you to try and get out if you can. Use that study leave budget, although it may be limited. See if you can get to some of these things. The first one is the Basics Pre-Hospital Care Conference, which is taking place on the 9th to 10th of October in Leicestershire. And Simon, you and I will both be there. I'm hoping to record some podcast episodes. I know you're speaking. I think you've done this conference before. I've not been before, but of course, Basics is the British Association for Immediate Care. And actually, we almost weren't able to record today because you were about to go on a Basics call. So I know you're deeply involved with this organisation.
Immediate care schemes in the UK, the Basics schemes, fantastic volunteer organisation, responding from home or responding in team vehicles in support of the ambulance service. Quite rewarding, a lot of work, a lot of training. Fundraising is always an issue. We've actually got a blog on it back on St Emlyns if anybody wants to go and have a look about what Basics is about. Yeah, great conference, really interesting and diverse group of people.
So that's the first one, and you just need to search Basics Conference and you'll find that on the internet. And the second is, I still say, my favourite conference of all time. Incrementum is coming back in Spain, in Murcia, in April next year, slightly later in the year, so it may be hotter and sunnier. 22nd to the 24th of April. They've invited some new speakers to join the old team, so you'll have all the old favourites, Scott Weingart, Sarah Krager, many more. Haney Malimat will be there this year. Chris Hicks is coming from Canada, Sarah Gray from Canada. The lineup is tremendous. And the cost is not that huge. You may worry, being if you're UK based, that getting out to Spain will mean that the conference is very expensive. But actually, even with travel, because the conference costs are relatively low, it is probably very competitive with other conferences. You might even attend closer to home. So please do look at the Incrementum 2026 and think about booking ahead. I know as emergency physicians, we tend to do everything at 3 hours, 59 minutes in the UK and leave everything as late as possible. But there are some early bird deals. And get in there and get that booked if you can. And Simon, the last thing just wanted to mention in passing is I am still knee deep in MedPod Learn. So this is a big project to try and launch a new app in the next coming months. So by the time you listen to this podcast, it may well be launched. It's an app whereby you can listen to medical podcasts and then use it for active learning afterwards and recording your activity. So not just being able to access top quality content, but alongside that, there'll be some educational notes, some multiple choice questions, and some ability to reflect on what you've heard, download that, and then have that for your appraisal folder. We're hoping to get it accredited for CME in different countries, both in the US and closer to home. And it's all pretty exciting, but it's taking up all of my brain space, and me and ChatGPT and others are spending lots of time together.
It looks an amazing app, this, Ian. I think it's going to revolutionize how people use their podcasts, and particularly around recording their CPD. This is something other organizations, Archem Learning, do this, of course, very well, but not for everybody and everything. So I think doing this is going to be great. I'm really pleased that you put the work in, and I think it's going to be a really popular app.
Let's hope so. And Simon, let's move on. Let's talk about some content from June and July. And as we've said, because of us both being busy and the team actually being busy, we can probably cover 2 months in one episode today. Quite a bit of toxicology to talk about, thanks to Greg Yates, who's producing loads of great content for us, and some other bits and pieces. So let's dive into some medicine, Simon, because that's the bit that keeps us interested and keeps us going. And the first post in June by Greg was actually a response to an episode Scott had recorded about serotonin syndromes. And Greg just talking a little bit about his experience with serotonin syndromes and in particular, some of the musculoskeletal manifestations of those and how they can be a bit confusing and you just need to be careful. Do you see quite a lot of this sort of stuff up in Manchester?
We see a fair number of people who come in with serotonin syndromes, often at the mild end. So these are people who've been put on serotonergic drugs and they come in with a mild temperature and there's not really very much going on. And that can be managed very easily. The ones that we're talking about here, and the ones that Scott Weingart was talking about on EMCRIT, and the stuff that we've talked about before on St Emlyns, is the much more severe end, where you get these very severe toxidromes, very high temperatures, rhabdomyolysis, hyperkalemia, low consciousness. And when I say hypothermia, like 41, 42 degrees C. I've been involved in several of these now, and I've got to say they're absolutely terrifying cases. Classic example would be often a young muscular male who's been out clubbing, has taken some drugs which has precipitated this, and then comes into the emergency department. They've been fit and well, just wanted to go for a big night out, took drugs, and then with no intention of killing themselves, and then 3 hours later they're dead. And it's just remarkable how awful this situation can be. The main feature is actually cooling them down, getting them as cold as possible. So ice baths and other associated technologies is really important, but it's tricky. In the middle group, it's a slightly different group where you're looking for things like the Hunter criteria, which people can go and look up if they wish to do so. And these are the criteria that define what a serotonin syndrome is. And the skeletal components of that are tremor, hyperreflexia, and clonus. And what Greg's done here, in association with the hypothermia, the altered mental status, and the autonomic instability, what Greg's done here is done a bit of a deep dive into how good those particular tests are, what the sensitivity, what the specificity is for those musculoskeletal criteria. And the bottom line is, they're not great, actually. There's quite a lot of inter-observer variability, even with trained clinicians who've got special interests in this area. And so the message that Greg was putting out is, if you see a patient in whom you suspect they're a hypothermic serotonin syndrome patient, and they don't have something like clonus, then don't use that to exclude the diagnosis. Still consider it as a constellation of signs and symptoms whereby you can come to a conclusion and then treat these patients. As I say, predominant thing is cooling, then benzodiazepines, and then specific therapies like ciprofloxacin. But yeah, we've got a few links on the blog about these cases, and I would strongly recommend people to have a look. And you do not want to go in to a severe serotonin syndrome for the first time, having not had a fairly good idea about what to do and a fairly good idea about what is going on.
And of course, do go and have a listen to Scott's episode on EMCRIT. Excellent as always. This is one of those topics that is ripe for exam revision as well, isn't it? Toxicology is a very easy thing to examine on, worth thinking about if you're at that stage in your career too. Greg also does make the point that we just got to be careful not to overdiagnose serotonin syndrome, because you can end up then giving treatments that could make neuromuscular symptoms and anticholinergic syndromes worse. So it is finding that sweet spot of making sure you've identified it and then done it.
Yeah, I'd agree. And one of the things that Greg introduced me to is, have you come across the concept of psychonauts, Ian? So psychonauts are people who, if I get this right, are people who are trying to explore the psychedelic universe and the idea that we've explored the physical universe. So they're using medication in almost like a gentleman Victorian, because it would be men because they're idiots, a Victorian gentleman's way of experimenting with drugs to try and get them into different states. And one of the aspects that can be done there is people using drugs which potentially precipitate serotonin syndrome, so like MDMA and its variants, of which there are many. And they're using a pre-drug, so something like bromocriptine, to potentiate the effects of that, to give them a deeper psychedelic experience. And then also buying on the internet things like ciprofloxacin. So actually people are basically experimenting on themselves with a drug which is going to potentiate the effects, then taking the drug, and then having in reserve their own stocks of ciprofloxacin to avoid them going into serotonin syndromes. There are people out there doing this. There are Reddit forums about this. There's all sorts of things. It's absolutely fascinating, but also incredibly risky. So if you do get one of these patients, I'd also just explore why, when, who, and how they took the drugs. And if it's just a party drug and it all went horribly wrong, then fair enough. But there might be people who are doing fairly significant experiments on themselves.
A psychonaut.
Yes. Everybody needs a hobby, Ian.
Yes. I know my partner thinks I should step away from a computer and spend a little more time in company, but I don't think she meant to do that. But I'll ask her, see what she thinks.
We need to get Greg on the podcast soon about this, because he's just so articulate about it, and it's a fascinating area.
and only going to grow, I think, with the heralding of new drugs. And we'll talk about that again in a moment. We mentioned earlier, Simon, that you've been busy with the college thinking about the urgent and emergency care plan. And Stefan, who does a lot of posts for us about this sort of system redesign and how emergency care works, he's heavily involved with this, both on a regional and local basis down in the Southwest. This is a big deal, isn't it, about what's going to happen to emergency care. Some of it feels a little bit dreamlike in that if only it could happen. And when I walk into work these days, I have to feel like there doesn't feel a lot of optimism. You're a bit more at the centre of it. I know your focus with the college's education rather than the policy stuff, but I'm sure you go to meetings, Simon, where you hear more about it. What do you think the central thoughts are about this sort of plan and how we're going to actually get any change in the UK emergency medicine system?
Yeah, first, I'm not speaking for college. Obviously, this is my opinion based on Stefan's blog and other sort of things that have been going on. College has a position, and then worth going to have a look at that. The urgent emergency care plan, yes, it is quite aspirational, but are we going to get there? One of the things I thought was quite amusing is they always call about these transformative agendas, and you've probably got a department of transformation in your hospital. And I don't mean to be mean to people, but transformation to me is like the invention of the wheel. That was a transformation. And actually what we're usually talking about is minor incremental change. Doesn't sound as good as a department. And I don't want to belittle any of the work that's done in those departments is great, but transformation is possibly a bit excessive. And I think that reflects this as well. We're not talking about a transformation. We're not talking about something which is going to radically change the way that emergency and urgent care is delivered. We're talking about making things better. So what's in this one? So go and read the whole plan if you want to. Go and read Stefan's blog. But in essence, the things for me are, number one, and a potential benefit for us, is a realization, an acceptance and a belief, and really pushing back on the organizations that are delivering to take a shared responsibility for stuff. We've seen a lot in recent years where one organization blames the other organization for their problems and don't work together to make it better. Not something that we have particularly locally, but I've seen issues of patients leaving one service like the ambulance service to go into the emergency department, and those two organizations really just looking at their own patch and not looking at this as a collective problem. So that's the same for hospitals, GPs, community care, ambulance services. It's about now the whole system performance rather than the individual aspects of it. Well, that's what it's supposed to be. With that comes tougher ambulance handover times. And then this concept of the mental health crisis centres, the mental health emergency departments, not sure what they're going to look like. Sounds like a good idea because the care that our mental health patients get in emergency departments is often, the care's okay, we do our best, but I was in the other day and there's people there for 180 hours and we're not that bad compared to other areas in the country. So there's more money for that, which is good, but let's hope it works and doesn't get taken to something else. And there's more of a push for getting us to go digital, hopefully with a federated data platform across the NHS, but let's see. And targets are going down. So currently got about 31 different targets in emergency medicine. They're pushing those down to 18, hopefully. And there's more money. They say 370 million into same-day emergency care, urgent treatment centres. And a lot of that is a common theme, isn't it? We'll divert stuff away from the emergency department. Get that, but often when you do that, you basically just increase demand. So it doesn't necessarily offload the emergency department. And actually, we're really quite efficient, to be honest. A lot of the emergency departments are really good at seeing patients. It's what we do. So maybe the investment's going the wrong way, but I do admit I've got my biases. The concern I have, or the college has, is we still recognise there's loads of people waiting over 12 hours. It's not new money that's coming in, really. We haven't really addressed the workforce issues. They're being addressed in other documents, and clearly workforce and performance are so close that there's a problem there. And there's very little on the big problems that we have, which is exit block and corridor care. I don't know. I think it's really good that people are going to look at this. I went to a meeting with the directors of this UEC plan, and they're really motivated and they're really keen to help us do things. And they're really positive about what emergency medicine does. So I think that's a bit of a change. I am positive about that, but let's see what actually happens on the ground. And things are pretty bad at the moment in our 30 degrees heat and the nice warm summer. Winter's going to be tough. And one thing they have said, one thing that I have heard quite a few times is we are not going to solve it by this year. This winter is going to be a tough one. We're looking really for future years, 2026, where we might see a bit of a turning point. So yeah, lots of positives, some negatives, and quite a lot of uncertainty.
The thing that I find with us locally, firstly, £370 million sounds like a lot, doesn't it? But that's half the budget. It's less than half of the budget that they need to run my hospital. So my hospital costs about 850, maybe 900 million pounds a year to run. So 370 million sounds like a lot, but probably not a lot in the great scheme of things. And my only anxiety is, much as we know time-based targets do represent something to do with quality of care, and people being in departments for too long is a bad thing, just shifting patients around to beat a target or to meet a target may not be a patient-centered approach. So moving a patient from the emergency department to an SDEC environment where they are off the clock, where actually if we just spent 5 or 10 minutes in the emergency department, we could have seen and sorted that patient and they would have been done and out, as opposed to then going to another place to wait in another queue, but the queue being off the clock, which seems to be highly important, is an anxiety I have. And I worry that though time-based targets have helped us a lot, many of us got jobs based on a time-based target. Actually, we've got to keep the patient at the center, and being shifted around continually just to go to a different area where a clock may or may not be active, I think can be really short-sighted. And I do see it a lot when I chat to colleagues around the country, that all that's happening now is we're just signposting people to a different area where the clock stops. So the 4-hour target will be better. And as with all things, the more pressure on a target, and we are, generally speaking, in emergency care and medicine generally, we're quite bright people and we will find ways to solve problems. And one of the ways to solve a time-based target problem is to find interesting ways to change the data, because actually the data is quite hard to interpret. And gaming is perhaps a bit of a extended word to use for it, but there are, I'm sure, certain areas where the performance looks great, but the patient experience isn't. And we need to keep that in mind. I know the college is very patient-centered, but as soon as we start to think just about numbers, that's when we probably are onto a doom-laden path.
Yeah, it's interesting you mentioned things like SDEX, because having had a look at some of the data, the type of patients that they take and the performance and how well they offload the work of the emergency department varies enormously. It does seem quite a local event. And there are places where the SDEX take off the really easy, quick wins, which probably would never require admission to hospital anyway and just need to be turned around at the door, and then leave the emergency department with the patients who are much more complex and actually can make your performance overall go down, of course, because it's a percentage of the number of patients who remain in the ED. So there's all sorts of complexities. And that's why the big thing I do like about this is take a whole system approach, that you can't just rob from one area to make it look better and then leave the other area as a dumpster. You know, that's not good. It's certainly not good for patients, as you quite rightly point out.
Let's think about something clinical. You did a Journal Club post about salbutamol as an analgesic in renal colic, and whether or not that might be something. I've never had renal colic, thankfully, touch wood, but those I've seen who have had it, it is a painful condition. And I think we've always been searching for something that's a bit better than a whole load of opiates to try and take that pain away as that nasty stone passes its way down a tube. Does salbutamol prevent any sort of possible thing for us? It feels a bit like when we tried to give magnesium for everything. Is salbutamol going to be the answer to this question?
I'll certainly try and answer that one for you. I have had renal colic. On TripAdvisor, I gave it 0 stars. Poor experience, wouldn't go back, didn't enjoy. And I think that's the experience for a lot of patients, isn't it? It's pretty awful stuff. The whole idea here is that obviously you've got a stone in the ureter and that causes spasm, and that's where the pain comes from, the pressure pushing back on the kidneys, etc., etc. Salbutamol, as we know, because we use it in things like asthma, is a smooth muscle relaxant, beta agonist. And so there is smooth muscle in the ureters. What happens if we give salbutamol to these people? Will it relax the ureters and allow the stone to pass? It also changes peristalsis in animal models as well, and it's excreted in the urine. So on face value, salbutamol seems like a pretty sensible choice, actually. So it's going to reduce the peristalsis, which causes some of the pain. It's going to relax the musculature, which allows the stone to pass. And it's delivered direct to where it needs to be. Does it work? So that was a question that was posed in this. It was a phase 2 trial. So this was a trial that was designed to see if there's any signal in this therapy. And then if this was a positive trial, they would then go on and do a phase 3, which would be a much larger trial. So it wasn't trying to quantify the effect. It was really just to look for whether there was anything going on at all. Single center, double blind, phase 2, randomized placebo-controlled trial. Lots of buzzword bingo in there for good quality type stuff. So it's a nice design. Patients are over 18, clinically suspected renal colics, and they were either given 250 micrograms of IV salbutamol or a placebo. So So a decent dose, that would be my starting dose for IV treatment in very severe asthma. It's a decent amount of stuff. And then they looked at pain scores going on a visual analog scale over from baseline to 30 minutes. And that's pretty reasonable to me. In a larger trial, you might look at some other outcomes as well. But if your pain is one of your main things, then let's have a look at that. So 108 patients were eventually put in. And to conclude, it made no difference. So there you go. So pain score in the salbutamol group was down 18 millimeters, and in the placebo group, 30 millimeters on their original thing. Small difference of 5 millimeters, which on a visual analog scale wouldn't be considered clinically significant, even if it was statistically significant. So really, they've decided that there's no real signal here for it. So let's not do it. Which takes us back to what you mentioned before, Ian, which is what about magnesium? Because magnesium seems to be used for everything and is exactly the same thing. It's a smooth muscle relaxant, which some people, not me, believe works in asthma. They've done those trials and actually it doesn't work either. So there you go. So smooth muscle relaxants don't seem to be effective in terms of magnesium and salbutamol in renal colic. So yeah, I was quite excited about this and then a little bit disappointed, but it's good science and I love science.
And if you want to read this paper, it's a good one for a critical appraisal, actually. Graham Johnson is the first author. And Sue Mason, who's been producing quality research in emergency medicine for many years, is the senior author, all out of emergency departments in the Midlands in the UK. So do go and have a look. And again, great to see emergency departments and emergency physicians producing this sort of research and asking these sort of questions, because you never know, one day we might actually find something that will do good, particularly in these nasty conditions where you want early pain relief and you want it pretty quick and ideally with as few side effects as possible. That was June, Simon. I think we do have time to cover July because there's only been a couple of posts and they are both along the old toxicological bent again. You did a journal club about hypothermia, a time-critical toxicology emergency, which we have touched on a bit already, but this is an actual paper review that I think is probably worth just having a quick chat through.
Yes, so I like this one. I say we've built up quite a number of posts about hypothermia in drug-induced situations on the blog, and I recommend people read these. Honestly, like I said before, if you see these patients, it's terrifying, and you can save lives. It's one of those situations you absolutely can save lives. So once your temperature goes above 40, it's directly cytotoxic. So that's what really kills these people. The drug-induced, whatever the drug that's induced them, temperature goes up. It's the heat which kills. And going back many years, people used to go, oh, this is very much like malignant hypothermia. Let's give dantrolene, which is a terrible drug to give. And you'll still hear people say, give dantrolene to these patients. It's falling off most of the toxicological recommendations now because that's not the problem here. It's not what the cause is. So there's all your general resuscitation things. So manage the airway, manage the breathing, manage the circulation, may need to intubate these patients for control. But the key is going to be about cooling. It's cooling, 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 cooling. So severe hypothermia is defined as over 39, and certainly when you get over 40, I'm really worried. And what are you going to do about that cooling? Have a think now about your emergency department, about you've got a patient now who's in bed 4 in resus, who's got a temperature of 40.8. How are you going to cool that patient on a day like today when it's absolutely roasting? So things you can do, ice packs to the axilla, groin, neck, yes. You can do misting combined with fans. Quite a lot of data came out of the harsh pilgrimage that's quite a good way of cooling people who've got hypothermia. You can use devices that you may find in your ICU, things like the Arctic Sun or the Altrix. They're pretty good and can cool people down those, but they may not be quick enough to get into the department. And then this ice water immersion, which is actually probably one of the best ways of doing this. Now, ice water immersion, you say, I haven't got a paddling pool in my department. And that's true. Some departments do. So some places that see a lot of hypothermia do have like paddling pools that are person shaped, put them on the bed and fill them with water and then put ice in the water. That's very effective. You can have a ventilated patient in like that. It is doable. And what I've done, because we don't have one in the past, is take a vacuum mattress. And if the patient isn't too big, I can actually get a vacuum mattress and I can form it into a paddling pool and put water in the vacuum mattress and put ice in that as well, and then stir that around to keep it cool. That's pretty effective. So those are all external cooling methods. They're really good. And then internally, you can do things like use cold IV fluids. They don't really have that much of a difference, but why not give them? You can use renal replacement therapy up on your ICU. They can put them on the CRRT, and that can cool them down to some degree. And it can also manage things like their acidosis and the hyperkalemia at the same time. It's obviously good. There are some catheter systems which are cool. They won't be available in many EDs, but if you've got a cardiothoracic center on site, you might be able to get access to those. And then if you've got ECMO, you can use ECMO, but we, as I've said many times, are ECMO. What's my message here? Do the simple stuff. You can usually find ice and water. Don't waste time trying to find an ECMO circuit in a hospital that doesn't have an ECMO service when you've got an ice machine in theatres. That's my big message. Cool the patients. And then when you've done all of that, knock yourself out with some cyproheptadine and some benzodiazepines, which you've probably given already as part of the resuscitation, but cool the patient.
And this is another of those high acuity, low occurrence events that we spend a lot of time talking about, but mainly because you don't want to have to think about this the first time when you see the patient. So it's another one that's worth thinking about. And this paper you can find in Emergency Medicine Australasia. It's published in June this year from the team down at Liverpool Hospital and the Poison Centre there in Sydney. So do go and have a read of that paper. Just while we're talking about fever, Simon, I had occasion recently where I was unfortunately in hospital with a fever, and I had rigors and was shaking and wasn't very well at all. And the very well-meaning member of the nursing team came in, took my temperature, spotted it was 38.8, and while I shivered away, and then proceeded to open the windows and take the blankets off me and describe it as being cruel to be kind and for my own good. Just a little note that if a patient's cold, please let them have blankets. It's a slightly personal thing. Obviously, if you're a toddler and you're worried about febrile convulsions, different thing. But if you're a 50-year-old middle-aged man and you're shivering, and the truth was I didn't have the strength to say, please can I have my blankets back? So I won't let her leave the room, and then 20 minutes later go up and shut the window. But yeah, you don't need to do that. Yeah, every time, just think of patient's comfort. It's one of those things, actually, isn't it, on a busy emergency medicine day where the little things make a difference. Getting a blanket, getting a glass of water. We keep banging on about it, but they can give real value. So alongside giving blankets, please don't take them away. That would be a little personal plea. Our final post, another one from Greg. Nitazines, a growing problem, I think, although I don't think, or maybe I have. I don't think I've seen these. These are these new opiates, I believe, but I don't have a lot of experience, hence why Greg's posts are so important to me. Is this something you're seeing more?
Yeah, we've seen a little bit in my part of the world. I went to a great presentation at the ARCAN conference, and it's worth also mentioning the ARCAN conference, which is next year, the new flagship one. Definitely worth going to that one in Birmingham. I think it was one of the Scottish toxicologists who was talking about nitazenes. I keep calling them nitazines, but it's wrong. It's nitazines. But essentially, these are synthetic opioids, and they're hugely potent. So heroin, if you take relative potency, heroin is a 1. Fentanyl, which is what I use a lot of in my clinical practice, is 50 times more potent than heroin. But then when you get into these nitazines, so there's a drug here called isotonin tazine, and is 250 times more potent than heroin. And there's some which are 500 times more potent than heroin. And the thing is that where you have issues of the supply of heroin, which is obviously a naturally produced substance, when we have periods of time when those are less available, then people will turn to alternatives. And these opiates can be either adulterated or substituted for what people are trying to find. You can get them online. You can get pretty much anything online, to be honest, these days, but pretty potent stuff. So there was a study in Glasgow in 22 to 24. They had a lot of related deaths there, 21 patients included, all of whom tested positive for some of these nitazines and other drugs as well. So xylazines, cocaine, diazepam. We often see this mixed overdose picture, wasn't it? So quite a few of those. And then there was another paper, 32 referrals to the Australian system in 2024. And again, all tested positive for these very high potency nitazines. So they're definitely out there. Of those patients who survived, quite a few of them had no idea that this is what they were taking. They were under the impression they'd taken just a normal opioid, a benzo, or a gabapentin or something like that. And that's consistent with what we see with a lot of other drugs knocking around, but they can be sold as all sorts. Oxy, Xanax, Valium were all purchased on the street. They turn out to be nitazines. Tricky days. What does it mean for us? There's an argument that some of these patients are naloxone resistant. And I've certainly had 2 or 3 cases now where I've considered nitazines as a possibility and given very large doses of naloxone to them. So what I guess I've seen people done before, and we've talked about it, is you see somebody with an opiate overdose, and you don't want to give them like all the naloxone in the world straight up, because you might put them straight into withdrawal, and that's a horrible thing to manage for the patient and for the team. So if people often give like 400, 800 micrograms, see if there's an effect. If there's no effect, consider it didn't work, so it's not opiates. I think if you're suspecting nitazines, you might want to go much higher and just intubate those patients anyway and do the cardiac and the respiratory supportive measures. So tricky stuff, really. In most areas, I think in the UK, there's a drug awareness or a drug surveillance service. We have one in the Northwest, which is the Loop. Amazing. So on a monthly basis, we get records of what's out there in the world. So what drugs are out there, what's being sold as what, and what the potencies are. And that's pretty helpful. So if you've got that service and you start seeing nitazenes in your population, then maybe you need to think about doing things slightly differently. Probably the biggest impact would be maybe trial higher doses in naloxone before you decide that it's definitely not an opiate overdose. But again, the evidence for that is quite weak. It's early days, these drugs are changing, et cetera, et cetera. Such is the world of toxicology. It's often complex, isn't it?
Lots to think about with toxicology for these last 2 months we've just covered. And Simon, that brings us to the end of June and July. And as we were saying before we pressed record, we are hoping to resume normal service when September comes. Both Simon and I, we're both on our holidays for the next couple of weeks. Looking forward to a bit of a break. Simon, I know you're going somewhere nice and warm, although it seems that everywhere is nice and warm. So please enjoy your holiday. And if you are in the emergency department in the UK or worldwide, keep going. We say this probably every month, actually. There are good things that we can be doing, and there are plans afoot to try and make things better. And as always, for me, the best bit is trying to be the best I can be on any given day. And that is about learning, and it's about being kind, and it's about having a good team. And we're often really fortunate with that. Thanks again for listening to the St Emlyns podcast. Don't forget to have a look at those conferences we mentioned. We'd love to see you at some of those. And if you do, please come up and say hello. It's always lovely to see people. We'll speak to you again very soon. Take care.